patients who exhibit heightened airway reactivity to normal or lower level of physical, chemical, or pharmacological stimulus to the airway. So, what is hyperreactivity means? Hyperreactivity means intermittent bouts of exaggerated airway narrowing, clinically manifesting as laryngospasm or bronchospasm. So, the hyperreactive airway occurs due to acute or chronic airway diseases. The acute airway diseases includes upper and lower respiratory tract infections, which may be due to bacterial and viral respiratory infections. The bacterial and viral infections are more common in children, but may also occur in adults also. Chronic diseases, such as allergic rhinitis, chronic bronchitis, emphysema, asthma are much more common in adults than the respiratory tract infections. And in chronic diseases, smoking is also one of the factors which may exaggerate reactive airway diseases. Regarding anesthesia considerations for this, anesthesia for these patients with reactive airway diseases may result in perioperative respiratory complications, results in breath holding, coughing, stridor, and desaturation, laryngospasm, bronchospasm, atelectasis, and pneumonia, postoperative pneumonia, maybe the considerations. So we must be dealing with these patients with a little cautious, and preoperatively we should manage these patients with preoperative medications to avoid all these complications. So regarding second one is we have discussed the etiology. Third one is mechanism. This mechanism for the hyper reactivity is in resting stage, the bronchial smooth muscles are in a state of mild contraction, usually as a result of this parasympathetic and the sympathetic tone. So this state of contraction is due to anatomical to find balance between anatomical dead space and airway resistance. To find balance between the anatomical dead space and the airway to avoid airway resistance also. So usually these anti-muscarinic drugs like atropine and glycopyrrolate usually abolish these tones. The airway resistance is also modified by other factors like airway amount of secretions, the presence of absence of mucosal inflammations and edema, in addition to the bronchial smooth muscle tones. So next is the neural supply to the respiratory tract, so that we know what exactly happening during the hyperreactive airway disease. So the neural supply to the respiratory tract is by the parasympathetic supply to through the vagus, which is more prominent than the sympathetic tone. The sympathetic supply is less prominent in respiratory tract. So usually the mucosa of the cartilaginous portion of the respiratory tract has a large number of surface receptors. The impulses from the mucosal surface of the surface receptors usually carried through the vagus nerve. From the vagus, it carried to the vagal nucleus in the medulla. So once if the vagal nucleus in the vagal nucleus in the medulla is stimulated, the efferent from the vagus nucleus carried to the parasympathetic ganglion to the nicotinic cholinergic receptors, and then it responds to the acetylcholine. In respiratory tract, there are three muscarinic receptors is there. One is the M1 receptor, second is M2 muscarinic, and M3. Usually, the M2 is in between, is a intermediate which controls the M3 also and the M1 also partially. So this M2 receptor will balance the M3 receptors to avoid the bronchial smooth muscle contraction, which prevents the bronchospasm. And aids in the bronchial smooth muscle relaxations. The airway hyperreactivity has been attributed due to the autonomic imbalance between the sympathetic and the parasympathetic responses with the relative overactivity of the parasympathetic systems. It occurs due to the three mechanisms. One is the overreactivity of the mucosal surface receptors. Second is the stimulation of the M3 receptors. This M3 receptors, as I told earlier, it aids in the bronchial smooth muscle contraction. And the third one is increased mucosal secretions. And the other factors are irritant stimuli, inflammations, which also maybe contribute to the mucosal edema and airway resistance also. Resistance also. These are the things in the neurologically. So in children, usually when the viral infections or bacterial infections occurring in the children, first of all, the respiratory mucosa epithelium gets damaged. So there will be an exposure of the sensory nerve endings will be there. So when the irritants get contact with the sensory nerve endings, there will be an increase in tachykinins. There will be increase in tachykinins and the decrease in the neutral endopeptides. Usually, the neutral endopeptides will decrease the tachykinins in this situation. So it aids in which aids in the broncho relaxation. So when there is an increase in the tachykinins, there will be a bronchoconstriction with the cholinergic transmissions. Cholinergic transmissions. Another factor is when there is a epithelial cell loss due to this the bacterial or viral infections, there will be a epithelial relaxing factors like a PGE2 and PGI2 in the bronchial smooth muscles. So it will decreases the beta 2 receptors. So in the same time, it will increases the muscarinic receptors, M3, particularly M3. So which increases the acetylcholine release, which increases the smooth muscle receptors, smooth muscle receptors to aid in bronchoconstriction in this acute and respiratory tract infections. So always there is a absence of negative feedback mechanism of the M2, which promotes the M3 overactivity in the bronchial smooth muscle constrictions. So there must be always there must be a constant feedback from the M2, which aids broncho relaxation in bronchial smooth muscle constrictions. Sir, hello?
Go ahead. I'm hearing.
Okay, sir. So this is more of physiology, so it would be sometimes the other peoples may feel very little bit evil. But once we read that the mechanism of this, it is very interesting and it is very, so we don't know, we'll come to know all these things. And the other thing is how to diagnose all these things. So diagnosis usually we'll do the CBC, we'll check for leukocytosis, and for post vital capacity. And we'll check for the FEV1, pulmonary function test, and all we'll do. So measurement of the peak expiratory flow rate and the FEV1 and PFT and all will aid in the diagnosis. But clinically, how we will diagnose it? If the patient is coming to us and if the patient is having multiple medications with repeated hospitalization and having the increasing need for therapy for respiratory tract infections or respiratory issues, we should raise the suspicion of hyperreactivity. So as far as concern is no definitive signs and symptoms can identify as a hyperreactivity. So we should be cautious on taking history. So while taking the history, multiple medications, repeated hospitalizations, the need for increasing therapy, maybe a concern for this hyperreactivity. That when the patient is concerned, they will have the dyspnea, nocturnal dyspnea, chest tightness on awakening, feeling breathlessness, and wheezing on exposure to cold air or other gas fumes. They will tell the respiratory irritants. So they will have a tendency to develop bronchospasm. So we must ask the history about these things also. So the history of smoking is another important factor, sir. We have to ask. So before preoperatively, we should stop the smoking for 1 to 3 months to aid the ciliary growth and mucociliary to improve the mucociliary functions. So cessation of smoking also one important factor. So in the diagnosis, we have to ask the history of the smoking also. And then regarding the preoperative pharmacological controls, we should ask about the sympathomimetics, what drugs they are taking and what and all they are using, puffs or the inhalers, what type of inhalers, how frequently they are using, and how many times they are using. So usually the beta sympathomimetics are used. And any other drugs, beta blockers for any other drugs they are using, we have to ask, and we have to give, if they are on the non-selective beta blockers, we have to give cardio-selective beta blockers like esmolol or metoprolol or carvedilol, so to prevent bronchospasm. So in beta 2 sympathomimetics, we can give salbutamol nebulization and salmeterol, terbutaline, levoalbuterol, uh, which aids in on the bronchodilation and bronchodilation. And the next is theophylline. There's a methyl xanthines like the theophylline and the aminophylline produces smooth muscle relaxation by inhibition of the enzyme phosphodiesterase and by the reduced degradation of the cyclic AMP. They do not have any selective action, but both by cardiac and the smooth muscle, they aid only cardiac and smooth muscle relaxation. So aminophylline also can be used in the acute setting. We can't use the theophylline and all, but in the acute setting, we can use aminophylline also. Aminophylline at the dose of 5 to 7 milligram per kg IV over 20 minutes as a loading dose, we can use, followed by 0.5 to 0.7 milligram per kg per hour, we can use as a maintenance dose. So we have to aminophylline. One of the side effects is tachyarrhythmias, and arrhythmias can happen. So we should check for serum aminophylline levels also frequently to prevent the adverse effects also. And steroids, bronchodilators, steroids should be given as inhalational and IV also. Inhalational fluticasone, beclomethasone, and budesonide and mometasone furoate mometasone can be used as inhalational agents with beta 2 sympathomimetics. Short course of oral prednisolone also can be used. So first we have to diagnose. First we have to check for what is the first we have to diagnosis, and for this we can use this step ladder approach also, like a step ladder approach of bronchial asthma treatment is there, so that we can select the treatment and we can proceed with one by one. And if the patient is moving more than 3 in the step ladder approach, we can refer to pulmonologist or chest physician to optimize the patient. So first one is step 1 is the preferred short-acting beta agonist. If the patient is okay with that, we can proceed with start. If the patient is not responding to that, step 2 approach is preferred in an inhalational load of corticosteroids. So alternatively, we can give bromelain sodium or montelukast. One is a mast cell stabilizer and one is a leukotriene antagonist. So if the patient is not settling with the step 2 also, we can move to step 3 approach. Step 3 approach is preferred approach is medium dose inhalational corticosteroids. So after this, ideally the patient should be referred to the chest physician, or else we can go to step 4 also. In the step 4 medium dose inhalation corticosteroids, plus either we can use long-acting beta agonist or montelukast. In step 5, the preferred treatment is the high dose inhalation corticosteroids plus either long-acting beta agonist or montelukast. Step 6, in that high dose inhalation corticosteroids with long-acting beta agonist or montelukast. We can use oral systemic corticosteroids also in this patient, like prednisolone. And we can taper it slowly. Taper it slowly. And then anticholinergics, ipratropium bromide, we can use it as a inhalational anticholinergic. So it acts at the muscarinic receptors of the parasympathetic system, and it causes a bronchodilation. It can be administered as a aerosol nebulization also, as adjunct to beta agonist. Both the glycoprotein and the atropine have significant bronchodilation properties, more useful in preventing bronchospasm. Usually, therapeutic action takes 20 to 30 minutes. So, preoperatively, we should give, and for patients of reactive airway diseases. So, it has another advantage of anti-secretory also. Anticholinergics, sometimes we should consider because it may make the respiratory secretions as more viscous. So if you are giving, we should give additional N-acetylcysteine also to come out with the secretions. And corticosteroids usually, as I earlier told us, it aids in anti-inflammatory, reduces airway inflammations, inhibit mucosal secretions, decrease the release of mediator substances. It does not prevent it does not causes any bronchodilation. It decreases the anti-inflammatory agents and airway inflammations alone. So it can be used as a prevention or acute treatment and the maintenance therapy, not as a not not used in the setting. Hydrocortisone we can help in giving during the bronchospasm at 1 to 2 milligram per kg. It helps in reducing the mediator substances and it does not causes any direct smooth muscle relaxation. Usually it should be given 2 to 4 hours before anesthesia as a preoperative preparation. Dexamethasone, regarding dexamethasone has both the glucocorticoid and mineralocorticoid. It stabilizes cell and lysosomal membranes, inhibit prostaglandins, and prevent the inflammatory kinins. So it decreases inflammations. It reverses the capillary permeability also. It is most commonly used for acute treatment. It is given as oral also for maintenance therapy. Prednisolone used as a maintenance therapy. Methylprednisolone we can give as parenteral and or we can give parenterally. So it has a rapid onset of action also. It reduces the inflammation and capillary permeability. It increases the response to beta agonist also by increasing the sensitivity of beta receptors, beta 2 receptors. The only corticosteroids that produces direct smooth muscle relaxation is a budesonide. In addition to its an anti-inflammatory effect, it decreases airway inflammation and hyperreactivity also. It can come as a suspended nebulized inhalation thing also. So other drugs and the master cell stabilizers, bromelain sodium, it inhibits the release of histamine and slow reacting substances from the master cells. It can given as a nebulized form also. Leukotriene antagonist is Zoluten, Zapeglucose, Montelukast. It inhibits leukotrienes and it inhibits the aspirin-induced cold air or exercise-induced asthma also. These drugs can be used as a prevention, not in the acute treatment of airway diseases. And magnesium sulfate also we can use. It decreases the release of acetylcholine at the neuromuscular junction. It inhibiting calcium-mediated smooth muscle contraction also. It inhibits thereby preventing bronchospasm. It can be used as adjunct, not as a sole treatment. So regarding anesthesia, drugs and airway reactivity, so in the induction we can give glycopyrrolate or atropine, and regarding opioids, as we can use fentanyl, remifentanil, flufentanil, and we can avoid morphine because it causes histamine release. It can cause histamine release and intravenous anesthetic agents we can use thiopentone. Thiopentone does not causes the bronchospasm. Only thing the respiratory reflexes will be more active. So when we are doing the laryngoscopy and the instrumentation, it causes bronchospasm. So it directly does not causes the release of the bronchospasm or any laryngospasm in reactive airway diseases. So when we are using thiopentone, we should use with other inhalational agents and or we should use additional drugs to keep the patient in adequate depth of anesthesia. And propofol has a mild bronchodilation property by the inhibition of the vagal response. On the other hand, it reduces the airway resistance also. It depresses airway reflexes also, and it well tolerates the airway instrumentations. And the ketamine causes bronchial smooth muscle relaxation directly by inhibition of the muscarinic receptors. And it also releases the endogenous catecholamines, which causes bronchodilatations. So ketamine can be used in asthmatic patients and to treat resistance bronchospasm during surgery or in intensive care also. Regarding etomidate also we can use. It does not causes the histamine release, and we can use safely. The only thing we should use with other inhalational agents with adequate depth of anesthesia. So it also does not suppresses any respiratory reflexes. So it keeps the respiratory reflexes more active. So in turn, the patient may develop bronchospasm also. And the inhalational anesthetics, halogenated hydrocarbons, causes of the potent bronchodilation properties. Usually, allothane is a drug of choice for bronchospastic diseases. Um, N-fluorine, isoflurane also causes bronchodilation, but in dose-dependent manner also. But when you are using on the theophylline or some other drugs with this halogenated hydrocarbons, it can cause arrhythmias and the myocardial depression also. Isoflurane also causes of the significant bronchodilation, but with higher more than 1.5 MAC, it causes bronchial smooth muscle relaxations. So desflurane, it is an irritant to the respiratory irritant effect on the respiratory tract. It induces bronchoconstrictions, so it can be avoided. But however, when given in higher concentration, it also causes bronchodilation. Sevoflurane we can give at 1 month. It causes bronchodilation with the least effect of tachyarrhythmias and myocardial depression when compared to halothane, N-fluorine, isoflurane, isoflurane. Then about the muscle relaxants. Muscle relaxants directly act on the muscarinic receptors of the neuromuscular junction M3. However, they also act at the parasympathetic ganglia M1, also producing unwanted side effects. Mostly atracurium. Atracurium causes the histamine release, which induces bronchospasm, which increases bronchospasm. We can use cis-atracurium, which does not release histamine. It has been safely used in airway reactive patients. We can use vepronium also, ropronium also. The only disadvantage with the vepronium and the ropronium is longer acting drugs. So the respiratory depression will be there in this type of patients with previous history of airway reactive. So we can avoid those drugs. If needed, we can use, but cis-atracurium we can use with no side effects, which does not cause histamine release. And regarding neostigmines, cholinesterase inhibitors, neostigmine which reverses the muscle relaxant effect, it increases the bronchial secretions and causes bronchospasm also. We should give with clearly we should use atropine or glycopyrrolate so that it decreases airway secretions and it takes bronchodilation and it avoids the side effects of neostigmine also. So if you don't want to use neostigmine, we can better use short-acting muscle relaxant and avoid a reversal with the neostigmine also to avoid the neostigmine side effect. And regarding narcotics and analgesics and sedatives, it causes most of the opiates causes respiratory depression and carbon dioxide accumulation, depresses the cough reflux, and decreases the cough secretions and decreases secretions through neural pathways. They also shown to depress vagal mediated reflex bronchospasm. So morphine we should contraindicate because of it's shown to release on the it causes histamine release also. It depresses the cough and bronchial reflexes also. So this bronchospasm caused by the morphine is only short-lived, and it can be avoided with concomitant administration of beta-adrenergic agents and atropines or with antihistamines also. Previously, antihistamines also like chlorpheniramine malate. It is a short-lived and very mild only. Pethidine we can use. Pethidine atropine-like action will be there. It suppresses vagal-induced bronchoconstriction. It is preferred when compared to morphine. Fentanyl increases airway resistance in susceptible patients, though it can be reversed with previous anticholinergics. We can use remifentanil, fentanyl we can use, um, and other adjuvants like lidocaine we can use. Lidocaine when intubating, before intubating 1 to 1.5 milligram per kg body weight, before 60 to 90 seconds before intubation we can use lidocaine. It causes it has it has 2-3 advantages. It improves the FEV1, it decreases the eosinophil count, decreases corticosteroids in mild to moderate asthma. It is effective in steroid resistant asthma also. So these are the various advantages. And while intubation, it mitigates the bronchoconstriction in airway hyperreactivity patients. It can there's a lidocaine we can use as a spray also during intubation also. 10% spray also is there, so we can use our nebulization also we can use. In the dose of the 1.5 to 2 milligram per kg weight, we can give nebulization up to 3 to 4 ml as a nebulization also through our normal nebulizer machine. And our goals, anesthesia goals, usually it is like we have to prevent the reflex airway reactivity in patients. Um, this involves specific management plan. So the children less than 1 year who have had acute or viral infection in the last 3 weeks can develop a severe laryngospasm or bronchospasm during anesthesia or postoperatively. The symptoms can be severe with a longer duration of infection also. So in such patient, it is wise to undertake surgery 4 to 6 weeks later. So we can avoid less than 1 year of age with history of viral infections in the last 3 weeks. So we can avoid this type of patients. And second one is a patient with a pre-existing pulmonary disease, such as COPD, asthma, to be treated adequately treated preoperatively with the bronchodilators. Then the respiratory secretion should be reduced, and just physiotherapy uh, should be done before undertaking of for surgery. And the patients presenting with the positive signs such as fever, mucopurulent nasal secretions, elevated WBCs, bronchi crepitations on auscultation, and radiographic findings have a higher degree of developing severe laryngospasm or bronchospasm. So we can avoid for surgery, we can avoid anesthesia in these patients, and we can optimize and we can take it up for later. Usually, laryngospasm is less common in children beyond 6 years of age. For children between 1 and 6 years of age, the rest benefit must be evaluated under the because the hyperreactivity may persist for 4 to 6 weeks after respiratory tract infection. So, if there is a chance, we can avoid surgery up to 6 weeks also. So regarding the regional anesthesia, it avoids endotracheal intubation, does not induce bronchospasm. Central neuraxial blocks tend to produce bronchodilation also. So we can use safely in hyperactivity patients as and when needed. However, if the patient if there needs higher level of sensory and motor blockade is necessary, there will be a difficulty in respiration. Um, Difficulty in respiration because higher motor blockade abolishes the respiratory muscle power, and in patients with bronchospasm who depend upon the axillary muscles for respiration, respiratory failure may occur. The incidence of hypoxia, respiratory secretion retentions, laryngospasm, bronchospasms are common in these patients. So when the patient needs a higher level of blockade, we may better manage it with general anesthesia with muscle relaxants. So preoperatively, we're taking before general anesthesia. We have to nebulize the patients. We ask the patient to do incentive spirometry, nebulize the patient with salbutamol, with anticholinergics like ipratropium bromide, and corticosteroids, inhalation corticosteroids like budesonide, fluticasone propionate. We can nebulize them 20 to 30, and we can give theophylline injections also 100 milligram IV, and preoperative corticosteroids like hydrocortisone or dexamethasone 30 to 60 minutes before injection also. So while intubation, we can use intravenous lidocaine also. 600 ecronium and the rocuronium can be used. So neosigmine we can use for reversal, but it has a bronchospasm disadvantage. So with so we can, if possible, we can use short-acting steroids and we can avoid this. And if the patient is having intraoperative bronchospasm, we should identify and we should treat. It will manifest as a peak airway pressures will be raised, the peak plateau will be low, the desaturation will be there. So it has a so we should treat the we should identify and we should treat bronchospasm also by increasing the depth of anesthesia, by increasing the data concentration, um, mm, and uh, and with the beta 2 agonist corticosteroids. Uh, corticosteroids and other agents. Regarding laryngospasm, which is more common in children, which is particularly after the viral infections. This is common during the induction of anesthesia. It can be treated with the muscle relaxants and endotracheal intubations. The laryngospasm may occur after extubation which should be treated with unified oxygen through face mask, hydrocodone supplementation we can give, adrenaline aerosol we can give for those patients. Um, so extubation for these patients we should be carried out with adequately oxygenated, good humidified, and if possible, you can take it in a deep plane also to prevent the bronchospasm and the laryngospasm. Regarding the ventilator management in these patients will have severe reduction in the expiratory flow. Airway reactivity patient, if they develop bronchospasm, they will have a severe reduction in the expiratory flow, and they will have a prolonged expiratory period also. They will have increased airway resistance, and premature closure of airways will be, hyperinflation will be there, and auto peak will be there. So this results in abnormal ventilation perfusion mismatch, and there will be an increased high airway pressures, which results in increased venous return to the heart. So hemodynamic instability and circulatory collapse also will be there. So the patient will present a severe respiratory acidosis and altered level of consciousness, and they will be unresponsive to medical management, and severe respiratory distress leading to severe fatigue and exhaustion, and coma also we can. So pulmonary ventilation in this patient, we can use the low tidal volume, increase respiratory rate, and lower inspiratory flow rate we can keep, and other strategies by expiration. We can avoid the expiration also. Higher expiratory resistance, we can avoid high expiratory resistance also. Usually the strategies will be the increase in respiratory time by decreasing the other strategies are increase in respiratory time by decreasing the rate and limiting the tidal volume and decreasing the inspiratory time also. We can keep permissive hypercapnia in the patient also to prevent hyper lung inflation and auto PEEP, and to avoid barotrauma also. To achieve normocapnia in this patient, maybe there is some PO2 level should be in the slightly in the upper range to avoid barotrauma, volume trauma. So paralytic agent should be used, and adequate control of the cardiopulmonary status also should be achieved with the sedation and other. So usually, conclusion, hyperreactivity disease are common and requires a definitive protocol for the management. Medical management before anesthesia, before surgery is much more important than intraoperatively. So with the proper understanding of the mechanism, the bronchospasm and the laryngospasm, we can avoid, and thereby we can reduce the postoperative complications. Thank you, sir.
Have you finished, Balasundaram?
Yes, sir. Thank you.
Okay. Taken almost 35 minutes for you to complete this answer orally.
Yes, sir.
When did you prepare this from? What is the source of your preparation?
Sir, I have prepared from the Karnataka Medical Journal is there, sir. So I have taken notes from that, sir.
Taken from the CME lecture or CME presentation.
A journal, sir.
It's a very elaborate one, but as I have been telling you in earlier classes,
okay, sir.
Your preparation should not only be informative, but it should also be concise, so that it will be a useful guideline for the other students and PGs too.
Okay.
Finish the answer within the 20 minutes time you have for each and every question, because we are now discussing more from theory point of view, how to write and present your answers in the theory question. So from that angle, you must be able to pick out the important points which are required to be highlighted, so that the examiner will have to just go through the answers within the stipulated time. They have very short time. They will have, when they are given 150 papers, they have very limited time. But Dr. Kamaji told me that nowadays they are giving some key to the answers also, and they just want to know whether you are writing those particular points correctly. If you write them, then they will give you adequate marks or get a pass. So you should always, whoever is preparing for these questions, you should keep it in mind that you should be able to write this answer within the allotted time for you. So
Okay, sir.
otherwise, it was a very elaborate and expensive preparation. But I have one or two questions to ask you.
Okay.
Is a reactive airway an acute condition or a chronic condition?
Sir, listen, sir, pardon, sir, please. Hello?
Are you able to hear me?
Yes, sir.
Is a reactive airway an acute condition or is it a chronic condition?
Sir, reactive airway may be acute and chronic also, sir. In acute
It can
means
be
it is
both acute and chronic.
chronic, sir.
Does
Yes, sir.
bronchial asthma come under this category of reactive airway?
Yes, sir. It comes under the reactive airway, sir. Acute exacerbation of bronchial asthma comes under reactive airway disease, sir.
Very good. So, what do you mean by a reactive airway? What are all the clinical things that happen when the airway is reactive?
Sir,
What are the effects on the respiratory tract when the airway is reactive?
sir, it causes
irritated or when it is stimulated, how
Yes,
does the reactive airway behave? What are all the things that happen or changes that happen in reactive airway?
it causes a breathing difficulty, sir. It causes cough with expectoration, sir. It causes
That is
breath
a
holding.
clinical presentation. But what
Yes, sir.
exactly happens at what level of the respiratory passage it happens?
It levels in the upper airway and lower airway, sir. Mostly in the lower airway in trachea, sir. And first
Lower
generation
airway is it trachea or upper airway? Trachea is upper airway.
upper
It's
airway.
the starting point of the airway, isn't it?
Yes, sir. Upper airway and the
So you must say which generation is affected. You know, respiratory passage, according to Weibel, is divided into 23 generations.
yes, sir.
Isn't it?
Yes, sir.
Starting from the trachea up to the alveolar tract and duct, there are 23 generations divided by Weibel.
Yes,
So,
sir.
in which particular generation this reaction occurs?
Sir, usually in the first 1 to 3 generations of the night is more common, sir. The
So
level of
can you
the
get a spasm or constriction of the trachea and bronchi?
yes, sir. We can get trachea, bronchi, bronchioles. We can
Will
get
they reduce in their diameter by constriction? They are all cartilaginous structures.
yes, sir.
Do you think they can reduce their diameter by constricting like a muscle? I think that point you have not understood. See,
Yes,
trachea, bronchi, major bronchi, up to generation 16 and 17, they all have a cartilaginous element in their anatomical structure, histological structure. Okay? So
Yes, sir.
anything with the cartilage, they cannot constrict. Only when they turn purely into a muscular passage with a smooth muscle, that
Yes,
part
sir.
only, a muscle only can contract. Okay?
Okay.
Whereas the narrowing or the passage becoming smaller is mainly due to the mucosal edema and secretions, as you have mentioned. So, three important changes happen in a reactive airway. One is mucosal edema, second is hypersecretions, third is constriction or shortening of the smooth muscles, which produces a severe narrowing. So, at that level, the passage itself is very narrow. And when it starts contracting and becomes much more smaller, which law will apply there? Which physical law will come into act if there is a narrowing of a passage or a tube?
Bernoulli.
Vidya? Sobika?
Hagen-Poiseuille.
Hagen-Poiseuille, yes, Hagen-Poiseuille. It will increase by 16 times. Okay, when the radius is decreased, it will increase by 16 times. Okay, so that is what you have to understand. These are the three things that will happen. Trachea, bronchi, and lobar bronchi, all those things cannot contract and reduce their diameter by becoming narrower. They get narrowed only by the edema and the secretion. Whereas only at the lower segment where there is a smooth muscle component, that only can go into spasm and constriction and produce a severe obstruction. Okay, so that is the first thing, and you elaborated very nicely about the mechanism of pathophysiology. But what you have to understand is there is a predominance of parasympathetic activity even at rest in the
Yes.
respiratory passage compared to the sympathetic supply. And the sympathetic activity is the one which keeps the bronchi dilated. Okay, and that is done by the circulating catecholamines more than the nerve supply of the sympathetic system. So that is the main difference. So whenever the sympathetic outflow, the catecholamine outflow is more, that is why we are using beta 2 agonist as a primary treatment, not any blockers of parasympathetic system. And as you mentioned, I don't know how many of the students understood, there are three types of muscarinic receptors, M1, M2, M3. M3 and M1 are the ones which are responding more to the acetylcholine. The M2 acts as a negative feedback loop to control the overactivity of the M3, which is present in the smooth muscle coat of the respiratory passage and causes an intense constriction. So whenever you want to deal with a patient with hyperreactive airway, what you have to know is there are no standard investigations with which you can brand a patient as a hyperreactive airway. We indirectly deduce that by doing the FEV1 or pulmonary function test, we elicit the degree of constriction or narrowing. Okay, so that is as an extrapolated point only we are trying to make a diagnosis. But clinical history and the patient's complaints are very important. Repeated attacks of respiratory problem, breathing difficulty, and the classical tightness of the chest. There are 4 types of dyspnea described in Miller. Patients, whenever they say they are feeling difficulty in breathing, he says, how can you describe what type of difficulty you have? So if a person does a very strenuous exercise like running, which is not, they are not used to, will they feel dyspneic or not? Supposing you run 1 kilometer, which you are not used to, Balasundaram, will you
Yes,
feel
sir.
breathless or not?
Yes, sir. Breathless, sir.
Yes.
Breathless.
So how will you describe that dyspnea?
Sir, dyspnea in some situation, sir.
No, how as a patient, how
It is
will
a chest tightness, sir. I love what
I feel exhausted. I feel very tired.
Yes, sir.
Whenever I breathe after a strenuous exercise, the patient will say, I am feeling very exhausted and tired. That is the description. And when a patient says reactive airway with bronchoconstriction, he will always say, I feel there is some tightness in my chest whenever I try to breathe. And so somebody is preventing the expiration. So that tightness will be the description. And when you have a cardiac ailment and you get a dyspnea, you will say, it takes me uh, effort. I need to put in a lot of effort to breathe. So that will be the description. So these are the things that are described in Miller, different types. So you must ask for the patient what type of difficulty he has whenever they complain of dyspnea. And with the history and the associated testing only, we can brand a patient as reactive airway patient. And this, as you rightly said, in pediatric patients, it is usually following a viral infections. And the patients who are having a diagnosed reactive airway can present to you either for an elective surgery or for an emergency surgery. So that is the next thing that you have to describe in your answer. So if they are coming for elective surgery, you have to pre-treat them or find out what, because they will be taking some treatment for this. Nobody will be suffering with the dyspnea and tightness and all those for days together. So you first try to find out what exactly the treatment they are taking, and then see whether that gives them adequate relief from this reactive airway, or the bronchospasm or constriction gets relieved, and then keep the drug in use and make them spasm free. And if it's a patient is a known bronchial asthma patient or asthmatic bronchitis patient, can you classify the severity of the disease? Is there any grading by which you can assess whether the bronchial asthma is how severe it is by the frequency or by the use of medications?
With the help of bronchodilator reversibility, we can.
That we can assess the response of the patient. I am asking about, supposing a patient says, I am a known bronchial asthma patient. By asking a few questions about the frequency of attacks of asthmatic bronchial constriction or the treatment modality they are taking, can you grade the severity of asthma?
Yes, sir. Episodes in
Mild,
the
moderate, severe.
The symptoms.
diurnal
Nocturnal
four symptoms of
exacerbation.
night and
Four grades are given in the books. I think
Yes,
most of you would have read about it.
Yes, sir.
When the attack happens only once a week, it is called mild.
Mild.
Then if it has happened more than twice or thrice a week, it is called mild intermittent.
Yes,
If it happens every day, it is called moderate intermittent.
Moderate.
And if he gets every day, it is called persistent.
Persistent.
So
Severe
these are all the four categories: mild, intermittent, moderate intermittent, and persistent type of.
persistent.
And the treatment, if the patient requires a heavy dose of steroids, that itself indicates that the patient is having a very severe degree of reactive airway. Okay, so this is how you find out the severity, and then assess always any comorbid condition. You should be able to assess the risk involved in that. Here, what is the risk? You know that if you have made a diagnosis of reactive airway and that patient comes for an elective inguinal hernia surgery, let us say a 35-year-old person who gives a history suggestive of reactive airway or say chronic bronchial asthma, he comes for a inguinal hernia repair. How will you assess the risk involved? One, we can assess by the grading what we just now saw: mild, intermittent, mild, persistent, and moderate intermittent and persistent. And then the treatment that he is taking. If you know all these things, what is the risk? How will you calculate the risk involved? Must wait. You must be anticipating a bronchospasm to happen at any time, isn't it? Whenever a patient gives a history of reactive airway and has been in treatment for quite some time, we must always prepare ourselves to manage the eventuality of an intraoperative bronchospasm. Okay? So one of the main things that you have to discuss in your answer is, in case a bronchospasm happens, whether it is an elective case or an emergency case, how are you going to manage that intraoperative bronchospasm? That is what is mainly expected from the answer that you write. Okay? So what I would suggest is, you can cut short all the pharmacological details that you have given, like the drugs that are used. You described almost all the drugs that are being used for quite some time. So all that can be curtailed, and you can spend or concise your answer on the mechanism, the pathophysiology. Then you can say how you are to optimize the patient, and then what are all the intraoperative problems you have to anticipate up to post-operative period. And if you take that into consideration, then you will make a complete and clear answer. Okay. So with that, I will just show you presentation.